Welcome to the next webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled Beating Physician Burnout with Behavioral Health Integration. Before we get started, please note that this webinar is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. If you have questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collaborative product of 8 of the nation's leading physician organizations dedicated to equipping physicians with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care in their practices during the COVID-19 pandemic and beyond. This webinar will cover Henry Ford Health System's journey to integrate behavioral health care and how such efforts positively impacted their team's professional satisfaction and overall well-being. And with that, I will turn the conversation over to Dr. Espiritu, Dr. Dizon, and Dr. Yu.
Thank you so much, Sam. And on behalf of Dr. Dizon, Dr. Yu, and our entire behavioral health integration team, we would like to thank American Medical Association, Chris and Sam, through the BHI Collaborative for this opportunity to share our learnings in implementing and refining BHI at Henry Ford Health System. We all know about the global mental health access crisis, and our system is not immune to this. So in 2017, we were charged by Dr. Bill Conway, who was then our CEO of the Henry Ford Medical Group, with implementing behavioral health integration across our system, which then at that time had 21 clinics and about 210 primary care doctors. And this was fully supported by our leaders in primary care, Dr. Diane George and Paul Szilagyi, and on the BHS side, Dr. Kathy Frank, who is our chair, and Donna Wellington. We did our due diligence by researching in terms of, what would be the best practices, what would be the best behavioral health integration model, and we settled for the collaborative care model at University of Washington Ames Center. We also went on a few trips to the Carolinas and Intermountain and collaborated with Mayo Clinic, same systems as ours. Our pilot was also supported by a grant from a private foundation, as most pilots are. So I am the psychiatric consultant who works with the whole behavioral health integration team. We had a behavioral health integration psychotherapist and started at your site, Dr. Dizon and Dr. Yu. And before we even go further, we just wanted to say that we don't have any formal disclosures or potential conflict of interest related to this presentation. So going back to, the behavioral health integration rollout pilot, I would like to ask Dr. Dizon in terms of, do you want to share some details about our model and why we settled on the particular approach, including why we opted for 100% virtual? Emmanuel?
Thank you, Dr. Espiritu, and good morning. So, we were really excited when our leadership wanted to help us to do a behavioral health integration. We had to look at a model that would best fit the needs of our large health system. We actually have a large geographic footprint and multiple primary care clinics. So we had to look at the different models of collaborative care, and we saw both telemedicine versus having an embedded therapist in our clinic. It was really challenging when we looked at our resources to embed a therapist in individual primary care clinics. And prior to the start of BHI, we actually had some experience with having embedded providers in a few clinics as part of some of other initiatives that we were doing. It The problem with that is that these schedules for these therapists would frequently fill up, and the access challenges that we were trying to address were not really being addressed. And the other challenge was that patients who were in other clinics did not have an embedded therapist that they could go to. So really, we were challenged with how can we provide real-time access to our patients, regardless of whether there was a behavioral health presence or not in our respective sites. When we looked at the research, we saw that telemedicine was just as effective as doing embedded therapy. And because of that, in our experience, as Dr. Espiritu mentioned, we had a chance to visit various areas and various health systems that were doing 100% telemedicine. And we were quite impressed with how telemedicine was able to reach out to patients remotely and away from therapists who are not in the office. So we decided to settle on 100% virtual, kind of a hub and spoke model. So essentially what happened initially is that if a patient presents to my office and I see that the patient has a need and fills some inclusion criteria, I would discuss with them the telemedicine model, which we call BHI. We put in a referral, and then the patient would make an appointment to see the therapist. We would let them know from the very start that this was a telemedicine appointment and not a face-to-face. And we also let them know that they would come back to our clinic and do the therapy sessions in a video-enabled exam room. So the therapy was actually done by a remote therapist in a central location, and the patient would come back to our clinic, so that it kind of is a hub and spoke model. So the patients wouldn't be anywhere except in our clinic. They wouldn't have to drive to a separate clinic or a separate facility to get their health care or their mental health needs met. And that's kind of what we settled on and began to develop initially. I wanted to get Dr. Yu's perspective on this and how that, her experience being my fellow primary care champion and being the very first site to do this program.
Thanks, Emmanuel, and Dorianne for that great introduction. I mean, it's been such an incredible experience to work with this team and see how the spread of this has changed our practice. And it's one of those things where you just can't imagine practicing without it. I'll give an example. So I saw a 25-year-old who in primary care yesterday, actually, who had irritable bowel, painful bladder without any urinary findings from urology, unaddressed anxiety for many years. She's been scoped, and we were able to, it was pretty clear that she was suffering from a lot of anxiety, and knowing that I had confidence that I had backup and the support from BHI, knowing that I know that they have their back, that they have my back, gives me just this enormous sense of relief that when I broach these conversations, I'm not going to be sending my patient out into the void. So we got into this conversation about her anxiety, and I was able to say to her right there, I have a team of therapists that I work very closely with. They can see you quickly, usually within 2 weeks. I have the confidence that I know I can say that. And they're going to make sure that we work together so that you feel better. And we're not going to let you go until we see that you get better. And if things aren't going well, they're going to let me know, and we'll come back together to make sure that you get better. And she walked out of there, I mean, just really just having her issues addressed in a way that she had never had it addressed before. And I was able to do that because I knew I had the support from a team that would follow up with her. I started her on Lexapro, and I knew that my team of therapists would be able to coordinate the care and make sure that she stayed on the medication or adjusted the medication if needed, helped her address side effects, and he would give her the tools that she needed to address some of her coping skills. So that's the kind of sort of where we are now, in that I'm not special in my group, and I know that any one of my colleagues can access this incredible service and have that level of support. Really, the confidence in that support and the relief from knowing that my patients are going to get access, they're going to get their issues addressed, and they're not going to let them go until things get better because of their registry model. And knowing that, Dr. Spiritu is going to be there also to provide her expertise if I get stuck is really helpful as well. So, that for me is sort of an everyday story in terms of knowing that I can address these issues in a very direct and immediate way. So, I think I'd be curious, Dr. Dizan, as the physician in charge of our site, how have you seen, as we've evolved our model from pre-COVID to post-COVID times, how has that changed some of the drivers of burnout that we've seen in our clinic?
I think, thank you, Dr. Yu. I definitely saw how COVID has impacted how we practice. And there was a lot of stress that we identified, not just with patients. Patients have been experiencing a great deal of distress because of this major disruptions in life. But this was also disruptive for our physicians as well. Were a lot of schedule changes, a lot of changes in order to maintain safety protocols. So we actually had to evolve rather quickly in our model. We initially started with a hub and spoke model for behavioral health, and the therapists would be remote, and patients would come into our clinic and go have their therapy sessions in an exam room. With COVID, we were trying to limit the amount of exposure to infection, and we were just toying with the idea of having remote therapy sessions from home, or actually away from the clinic. And basically, it was beginning to be adopted widely, but COVID basically forced us to go 100% remote. And having that learning, we found it as actually just as effective, having patients do their therapy sessions away from the clinic. Initially, there were concerns of, how are we going to address X, Y, and Z? But it turned out that patients were very happy to not come to the clinic to avoid exposure. And providers were very happy to know that they could still refer our patients to BHI and know that they were being taken care of. Our primary care physicians were doing a lot of remote video visits also. So I think that the comfort level with video visits for the primary care, as well as knowing that BHI is 100% virtual, I think that the jump to going remote was actually quite easy and very reassuring, at least in my experience and the experience of my colleagues who work with me. They were a lot more comfortable making that transition. And they were very grateful for the fact that BHI was still up and running, even in the midst of the worst of the pandemic. And I didn't know if Dr. Spiritu had thoughts on how the pandemic has changed how you guys did it on the behavioral side and the benefits of that.
Yeah, so it's been written that behavioral health integration is one of those initiatives that can really address the fourth aim, which is improving the work life for healthcare professionals. So I'm going to talk a little bit about pre-pandemic. In BHS, it is always difficult to get patients in when we need to see them at the point in their lives when they are in crisis. It is difficult to get patients in when they are ready to come in and see us. We tell them, when they call for a panic attack, for example, we tell them, unfortunately, we can't see you until 6 to 8 weeks from now. And how would you imagine, where the patient would go? And again, this was all prior to the mental health pandemic that we're experiencing now. Our slots are always filled. And no matter how many psychiatrists and mental health providers we hire, it will never be able to address the demand. And primary care physicians were at a loss or where to send their patients. If they do refer to behavioral health clinic, they really don't know if there is a way if they have a way of tracking if their patients were seen, if their patients were being treated, or where their patients were. BHI has allowed us to address a lot of this with the use of a registry, like Dr. Yu mentioned, and working very closely with the primary care team, we formed a bond. And so even before the pandemic, it was like almost a personal approach when we would send recommendations. We would know when a primary care is close to retiring, and we would just like, oh, we're sorry you're retiring, but then, what was very good, at least from our end during the pandemic, is, we all, it was very evident that each of us needed some encouragement in one way or the other. And because we already had this bond and formed a collaborative community, it was very easy to add on to your recommendations. And by the way, how are you doing? How's your family? Please stay safe, have a good weekend, enjoy the weather. And these were things that, primary care doctors appreciated. They would like write a personal note saying, thank you for checking on me. So, it also helped us help each other, not just our patients, but, from the wellness point of view of, behavioral health clinicians and primary care docs. So, Eunice, you have something to say?
Oh, I was just going to say, Dr. I think that really speaks to the culture that you built as the leader of the BHI team, that even though the whole team was working remotely, essentially from home, and doing, mobile to mobile visits, that you guys still stayed connected with each other, and you guys supported each other throughout the pandemic. I know you guys did some things to help each other out and stay connected, but then also that you were maintaining those relationships with the primary care, customers that you were serving. Yeah.
Yeah.
I definitely agree with Dr. Yu, and we really appreciate, the personal messages, and knowing that we are taking care of our patients together, and we're all in kind of one, we're kind of all united. I think that what helps with wellness is the fact that we're part of a community and not just kind of separate silos, or I am by myself with my practice, with my patients, but actually we're a kind of a community where we can all work together and we can all support one another. And I think that highlighted so much more, that was highlighted so much more during the pandemic. And I really appreciate the ability to kind of collaborate with you guys.
Yeah, just that confidence and the support and the relief that comes from having that support in a reliable way. And I do want to say, we're painting this very rosy picture of where we are, and maybe we should talk about some of the challenges that we had along the way, right? So, when we first started, just bringing in any program, even if it's a program to help and to support, is always a lift. It's always a change management process. And we had many PDCA processes, and we still do them ongoing to make sure that our processes integrate well with primary care. And so, I think just from my perspective, I remember some of the biggest concerns when we were first bringing this in. The biggest pain point from my perspective as a primary care doctor pre-BHI was really the access. It was that I would refer someone to behavioral health, and then 5-6 months later, they would come back for the same issue, and they still would not, and I would say, oh, and by the way, we're addressing your pain, but, we talked about going to see behavioral health, how did that go? And they're like, oh, well, they put me on a list and they said they'd call me and they haven't, so, you're kind of like at a loss. You never feel like you have that support that you need from the disciplinary team to manage so many issues in primary care. Whereas now I feel like, so when we were first coming in, really saying our service standard in behavioral health integration is we're going to see your patients in 2 weeks. And we're going to reserve same-day slots so that if patients are in crisis, they can be seen right away or same day. And we really focused on that in our metrics on our dashboard, really making sure that we were maintaining that service standard. And when we see that going down, we know we need to hire more people. So really, maintaining that as like the big thing, but that's really our big selling point, because we do have, because BHI, the collaborative care model, is based on getting people better and then graduating them into remission and monitoring so that they maintain those open spots. So it's not like not as bad as traditional, as difficult as in traditional behavioral health, where the slots fill up and then you keep seeing the same patients over and over. Then you immediately fill up that access because you'll never have enough therapists. But we kind of, when people get better, they understand and expect that they're going to go into remission and monitoring. We set that up as an expectation from the beginning. So that I think has really helped in that we focus on that access piece, and that it's going to be high quality access, that we're really focused on outcomes, results, and seeing those scores go down. And if they don't, then we're going to be doing step up therapy. So I think when we were first going to frontline staff who already have too many things to care about, that was really the pain point that we focused on at the beginning. I'm curious if you guys had other things that you felt like we needed to address early on.
Go ahead.
Oh, go ahead, Emmanuel.
Well, actually, I agree with Eunice. I think what was really crucial, and especially with Ford Road, is since this was a new program, we had to really sell it. And I think that having a primary care champion that was really convinced and passionate about it really helped us sell the program, because there was a lot of skepticism. We were one of the clinics that had an embedded therapist, a provider. And so telling them, okay, we're not going to use this provider, we're going to go virtual, it almost to them seemed like a step back. But then letting them know that we actually can see these patients sooner, and that we can get more real-time therapy, more real-time access. And it took actually demonstrating it live, having what we call dress rehearsals to show our frontline staff and our support staff that this is a model that works, and it can be it can be effective. But we really had to sell it. And as we went in multiple iterations of rollouts, we started to see the fruit of it, because people talk in the organization, they started talking about, oh, there's a program that we're in called BHI, we really like it. And so the engagement actually got bigger as we continued on. But the initial first site, was what was we calling the activation energy to get people on board, But that was my experience trying to get people on board.
Yeah. All those are very, difficult challenges in the beginning. But I know that the secret sauce was having you and Dr. Deason and Dr. Eunice as physician champions. What has also been a learning experience for me is that we're not only engaging the doctors, it's exponentially engaging everyone in every clinic that we went to. So starting from the customer service representative who were doing the enrollment and logging them back in, into the clinic, the medical assistants, the nurses, group practice directors who were actually our marketing people, because they saw how good the program was. And so they were the ones who were actually saying, like, when is my clinic going to come in? And so having a very organized curriculum, we had slides, we had to engage every single group instead of just preaching to primary care doctors. So that was one of the things that I thought made it much easier to spread, because if you think about it, we were very nervous. Once the pandemic hit, we weren't meeting our goal of spreading to the whole system. But yet, even during the pandemic, we were able to finish 32 primary care sites. I mean, that is an amazing, journey and accomplishment, but it's all because of, I think it's a collaborative approach, and everyone was, into this and supported by leadership. So, that was one of my lessons learned.
Yeah, definitely. I think exactly like that, having those processes and protocols so that we could hit each site and do it in a standardized way while allowing that site to kind of tailor a little bit. And that was especially important when we were doing like hub to spoke, when we were doing site to site, care pre-pandemic. Once it became all mobile, then that rollout became much easier. People just needed to know what the program was, but some of the roles, became much simpler. Like we didn't have to room patients. We didn't have to, check them in for the special program, things like that. And then I think in addition, just piggybacking on the 360 engagement, in addition to engaging the primary care teams, but also engaging the patient. And I think part of our list also at the beginning was helping clinicians engage patients to do this program, because it's a little different than just being referred to a therapist and going to an office and kind of what people already expect. It's sort of helping clinicians understand how to engage their patients in this very collaborative process, because the patient's really at the center of the collaboration. Sam, if we could actually put up the slide that says the 4 C's. So we came up with a mnemonic to help ourselves and also our teams remember what is special about the behavioral health integration program, or the collaborative care program. We called it the 4 C's, and one of the C's is actually a Q, but those 4 C's are quick, convenient, collaborative, and coping. And these are things that I actually say when I talk to patients about this, and it's what we say when we ask clinicians to talk to their patients about it. So kind of hitting those big points in that our service standard is to see within 14 days. It's going to be convenient because you're going to be able to do it from home when you're on your lunch break in the parking lot. Please pull over if you're driving. Collaborative in that the PCP remains the doctor and sort of the main prescriber, that it'll come back to me if things aren't going well or we need to step up therapy, that there's a collaboration if the patient has a lot of issues and needs longer term therapy, that they can go on to behavioral health and there will be a warm handoff there. So collaborating both PCP and behavioral health. And then, the big question was really around patient selection, in that BHI was really a program for mild to moderate presentations of mental health, and that really the best way that we thought of who would be able to benefit from BHI were folks who needed help with coping, and that is they would do 6 to 8 sessions of brief therapy and coping skills, along with sort of a case management approach around medications. And kind of getting folks better on their PHQ-9 and GAD-7 scores. So, we have a lot of other metrics, but I think one other thing that we'd like to share in terms of kind of the impact of this program is, if we can go to the next slide, we did do a case control study using the patients who had been referred to BHI compared to similar patients who were not referred to BHI, similar in terms of demographics, characteristics, and their initial PHQ-9 and GAD-7 scores, and looked at their rate of PCP visits per 1,000 in a 3-month cohort and a 12-month cohort, and we did it over different time periods. And the most robust finding was really that after BHI, patients who were in BHI had many fewer PCP visits. And this was, replicated in different times and again, like with different populations. So this turned out to be a pretty robust finding. And we were really, my take on that really is that, just like the patient story that I shared earlier, it's that people have these interconnected issues and we really need that multidisciplinary approach to address them well. And if not, they keep coming back to us and we try to address it, but we don't really get to the core of the issue. When we get to the core of the issue, we're able to bring down the number of visits to PCP for the same thing over and over, and we're able to address that more effectively. So that was something that we found, and I think also contributes to that feeling of relief, right? Like I don't have the same patient coming over and over that I can't really help because I can't get them access to the services they need. So any last words? Dr. Spiritu and Dr. Dizan, I know we're coming up to our time here.
Yeah, we so appreciate this ability to be able to share this, but even if we're coming from a big system, fee-for-service point of approach, this will also be applicable to smaller clinics, because even if, for as long as you have an organized way of spreading behavioral health integration, you will be able to engage one patient at a time, one primary care doctor at a time. So, and that's all for, a collaborative community. Emmanuel?
I agree, Dr. Spiritu. I think that this model can be brought to scale. So we're a large clinic or a large health system, so there are more moving pieces. But even taking a small clinic with a couple of physicians, you can easily bring it to scale. And there are many ways and many iterations of BHI telemedicine. I think that you can do, and really, it's having a primary care champion or somebody who's really invested in doing collaborative care. I think that's really the secret, is making sure that the person that is going to be involved in the spread is really engaged and really motivated to overcome the activation energy that's required to get people on board. And that's something that we really learned during our implementation.
Yeah, thank you. And I just want to say from our team and from Henry Ford to thank the AMA for giving us this opportunity to share our program. And Sam, I'll hand it back to you.
Great. Well, thank you, Dr. Dizon, Dr. Espiritu, and Dr. Yu for sharing your experience and expertise with our viewers today. We really appreciate it. Please be sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on our YouTube playlist, which is listed below on this slide. Please also check out the Collaboratives resource, the BHI Compendium, for a helpful framework on how you can make BHI effective in your practice. And with that, we just want to thank you all for joining us today.